I'm Hsiao. I'm a dermatologist at the University of Southern California, and I'm here at the Summer AAD talking about HS. My session covers off-label approaches to recalcitrant HS, and I have 3 tips for you guys today. So tip number 1 is to always consider a multimodal approach to therapy. For HS, we have both medical and surgical options for therapy, and when we think about medical treatments, we can also do treatment stacking. What does that mean? It means that we have our core therapies, so for example, our biologic or small molecule inhibitor for our patients with moderate to severe disease, and we can also pull in from other classes. So for example, are there topical therapies we can use, metabolic or hormonal therapies like metformin, or even GLP-1 agonists, maybe spironolactone for women. There's multiple off-label ways that we can kind of help use our core therapies and get better optimal outcomes. My second tip is to think about incorporating therapeutic drug monitoring for patients. So for our patients who are on adalimumab, which is FDA approved for HS, or infliximab, which is off-label for HS but very helpful for patients with severe HS, you can think about basically getting a lab test done for them to check their drug trough level and also anti-drug antibody level before deciding, for example, that the patient may need to move on from therapy. So let's say they were on the drug, they were doing well, efficacy starts to wane, you can get that drug level, get the antibody anti-drug level, and basically check, maybe I can actually dose escalate instead of switching. And finally, third is to think about dual immunomodulator therapy. And so this really borrows from our GI colleagues who have patients with really terrible inflammatory bowel disease, or our sort of rheumatology colleagues with patients with recalcitrant rheumatoid arthritis, where they are combining, for example, dual biologics or a biologic and a JAK inhibitor for those recalcitrant patients. And I feel like for HS, we do have those patients where we've done our best. We put them on a biologic or small molecule inhibitor. We have sort of optimized their multimodal way, their adjunct therapies, procedural therapies, but unfortunately, there's just this efficacy ceiling that they keep hitting. In those cases, I would say it is a conversation with patients, but you could consider combining 2 biologics together or a biologic with a JAK inhibitor. And so, for example, really commonly used combinations might be a TNF inhibitor plus an IL-17 inhibitor, or considering IL-17 with a JAK inhibitor. Just remember to counsel patients about potential increased risk of infection and letting them know that there's not rigorous data supporting this. It's really, I think we probably need trials studying this to really get a better understanding of efficacy and safety. But for those patients who really just don't have that adequate quality of life on monotherapy, immunomodulator therapy. And finally, I would just say there is a very robust pipeline for HS right now in terms of drug development. But while we're waiting for that, and hopefully that translates to better outcomes, we can optimize our use of the FDA-approved therapies we have now, and also really think about the sort of off-label therapies that we can use in conjunction to get patients to where we want them to be. Thank you.